So let's set our baseline right out of the gate. For a patient to actually survive and get adequate dialysis, any vascular access we build has to support a continuous blood flow of 200 to 500 mLs per minute. That 200 to 500 range, that is the absolute physiological target we're aiming for.
Here's our roadmap for today. We're covering indications, temporary catheters, pre-op evaluation, permanent access, and finally, complications.
Okay, Section 1. Let's look at the indications for renal replacement.
You've really got to differentiate your timelines here. Short-term, urgent access, that's mandatory for acute emergencies. Think severe fluid overload, symptomatic hyperkalemia, intractable metabolic acidosis, or serious intoxications. But long-term access, well, that's built for your stage 5 CKD patients who are facing intractable uremia, fluid overload, or severe electrolyte imbalances. Basically, short-term is your immediate rescue, and long-term is for sustainable management.
Moving right along to Section 2, temporary catheters.
You'll want to memorize this direct comparison. Non-tunneled catheters are your quick, bedside solutions for short-term use, usually around 7 to 21 days. Tunneled catheters, though, require surgical sterility for placement. They physically separate the skin and vein puncture sites, and by using a subcutaneous cuff as a physical barrier to bugs, they actually become suitable for intermediate-term use over a few months.
So let's test your attention for a second. Out of all the access modalities we use, which one do you think carries the absolute highest risk of infection?
If you guessed tunneled dialysis catheters, you're exactly right. And the magnitude here is honestly staggering. We're talking a 10 times higher relative risk of infection compared to a mature arteriovenous fistula. This often shows up as a severe exit site infection or even systemic bacteremia, which, as you know, carries a really high mortality rate. Since permanent access is so much better for patient survival, let's move to Section 3 and walk through the preoperative AV access evaluation.
This evaluation has to follow a strict sequence. First up, a thorough history, checking for things like previous central lines. Second is the physical exam, including bilateral blood pressures and an Allen test to make absolutely sure there's enough collateral circulation to the hand before we mess with the blood flow. Third, we do a Doppler duplex ultrasound for vessel mapping. And finally, diagnostic imaging like venography, which is still the gold standard if you suspect central venous stenosis.
Now, timing is a heavily tested concept. How far in advance should this whole surgical evaluation actually take place?
You need 6 months of lead time. Seriously, planning has to start the moment the patient hits CKD stage 4. That means a GFR of less than 30. This 6-month window is absolutely crucial because it ensures the permanent access has the physical time it needs to be placed and to fully mature before dialysis is urgently required.
Okay, Section 4. Let's contrast our two types of permanent access, AV fistulas and AV grafts. From a surgical standpoint, we always prioritize distal sites first, like the radial cephalic junction right at the wrist. Why do we do that? Well, it's to minimize flow-induced ischemic steel complications and to deliberately save those proximal veins further up the arm for future access, just in case that distal site eventually fails down the road.
Here's your core trade-off. Arteriovenous fistulas use native autogenous veins. They have amazing longevity and a much lower infection risk. But the catch is, they suffer from high maturation failure rates. They can take anywhere from 4 to 16 weeks to mature. Arteriovenous grafts, on the other hand, use a synthetic tube. Sure, they let you cannulate earlier, but they are plagued by repeated thrombosis, way higher infection rates, and honestly, pretty poor long-term patency.
Even perfect surgeries fail sometimes. Which brings us to Section 5, our final and most heavily tested area, access complications and management. Time for another rapid-fire question. What is the single most common reason an AV graft fails?
It's thrombosis. Clotting is the primary culprit here, responsible for the vast majority of access dysfunctions. It often forces us to do an urgent surgical or image-guided thrombectomy just to salvage the graft. But you need to understand the root cause. This thrombosis is usually driven by an underlying stenosis caused by venous neointimal hyperplasia, or VNH. It's a physiological response where the blood vessel walls thicken. Think about it. You've got intense, high-pressure arterial blood continuously slamming into a delicate venous outflow system. The vein reacts by thickening, which restricts the flow over time.
So, knowing why this stenosis happens, Where and anatomically is it most likely to occur in an AV fistula?
It happens right at the juxta-anastomotic area. This spot acts as a classic bottleneck where flow-limiting stenosis develops, and you have to proactively treat it with balloon angioplasty before a full-blown thrombosis can actually set in.
Another devastating complication to watch out for is arterial steal syndrome. This occurs when the massive volume of blood diverted into the high-flow access literally steals perfusion away from the rest of the limb. In some patients, this triggers severe ischemic pain, worsening neuropathy, or incredibly even irreversible gangrene in the hand.
Managing these complications is highly algorithmic. You use balloon angioplasty for stenosis. You do an early thrombectomy for clots. Give targeted antibiotics for native fistula infections, but you have to do an excision and bypass for focal graft infections. And remember, if severe steal syndrome or high-output congestive heart failure occurs, mandatory flow reduction or complete access ligation is non-negotiable.
With stenosis and thrombosis remaining the absolute Achilles heel of hemodialysis access, it leaves us with one critical thought to end on. As synthetic grafts continue to fail from these complications, how might future innovations in biocompatible materials finally mimic the lifelong durability and resilience of our own native autogenous veins?